Hello and welcome to video of the February 2019 Journal of Vascular Surgery and the 4 papers that are now available for you to read, as well as many other excellent papers. The editor's choice and CME article for this month is entitled Outcomes of the Gore Iliac Branch Endoprosthesis in Clinical Trial and Real-World Registry Settings by Schneider and co-authors who participated in the Gore sponsored US IDE pivotal trial and some also in the GREAT real-world IBE trial and registry. The IDE patients were more likely to be treated with percutaneous access methods, with 55% versus 40% in this group. 3 IDE patients and 3 GREAT patients underwent 1-month interventions or re-interventions, with 2 IDE re-interventions, or 2.1%, and 1 GREAT re-intervention at 1.6% for thrombotic events. 5 additional patients in each study underwent re-intervention through 6 months, all for non-thrombotic events. Internal iliac limb patency was 94% and 86% at 12 and 24 months in the IDE study. In the IDE trial, 3.4% and 4.1% of patients underwent re-intervention at 12 and 24 months respectively for treatment of type 2 endoleaks. At 24 months, 8.7% of the IDE patients exhibited the abdominal aortic aneurysm sac expansion. 21.7% exhibited abdominal aortic aneurysm sac regression, and no patients exhibited a common iliac aneurysm sac expansion, while 45% exhibited common iliac artery aneurysm sac regression. The authors concluded from this detailed study that in the midterm that IDE outcomes and 6-month outcomes in the worldwide GREAT registry are comparable, and that common iliac aneurysm repair with an IBE device is safe and effective. Thrombotic events are uncommon and concentrated in the first month after the index procedure, and they typically can be resolved with endovascular re-intervention. Most type 2 endoleaks close spontaneously, and a few are associated with aneurysm sac enlargement. A second paper of the month, in-hospital versus post-discharge major adverse events within 30 days following lower extremity revascularization, by Lang and co-authors from Beth Israel Hospital in Boston, examined the timing of postoperative complications in 14,125 patients entered into the NSQIP database for lower extremity revascularization, with 63% having a bypass and 37% undergoing a peripheral intervention. For chronic limb-threatening ischemia, 30-day mortality was similar between PVI and lower extremity bypass, and in-hospital deaths only accounted for 43% of the PVI mortality and 65% of the bypass mortality. Major adverse cardiac events occurred post-discharge in 37% of the PVI and 18% of the bypass events. The 30-day reoperation rates were 5% for PVI and 8% for lower extremity bypass, with more than 1/2 occurring after discharge. The authors concluded that major adverse events occur less frequently after PVI than lower extremity bypass. However, a significant number occur after leaving the hospital, especially after PVI. Later PVI events may overestimate its benefits compared with lower extremity bypass if only in-hospital data are evaluated. These data demonstrate the importance of reporting 30-day rather than in-hospital outcomes. The next paper, randomized trial of vanopanet patency to promote radiocephalic fistula patency and use for hemodialysis, by Blyer and co-authors who participated in the Patency 1 trial. They evaluated the efficacy of a recombinant human elastase in promoting radiocephalic fistula patency. In a double-blind, placebo-controlled trial, 210 patients were treated topically with vanopanet and 103 were placebos. The 12-month primary patency rate was 42% for vanopanet and 31% for placebo, which was not statistically significant, while the 12-month secondary patencies were 74% for vanopanet and 61% for placebo. The authors concluded that vanopanet did not significantly improve primary patency, but was associated with increased secondary patency. The final paper, Epidemiology of Fatal Ruptured Abdominal Aortic and Other Aortic Aneurysms in the United States, by Abdullah and co-authors from Boca Raton, Cleveland, and Chicago, described the trends of deaths due to ruptured abdominal aortic aneurysms in the United States from 1999 to 2016. Using the U.S. National Vital Statistics System and ICD-10 codes for ruptured thoracic aortic aneurysm, ruptured abdominal aortic aneurysm, and ruptured thoracoabdominal aortic aneurysm. A total of 104,458 deaths due to ruptured aortic aneurysms occurred during the study period, with an overall age-adjusted incidence of fatal ruptured aortic aneurysms of 23 per 1 million. The annual incidence of ruptured aortic aneurysms decreased by 68% from 1999 to 2016. These trends were consistent across age groups, sexes, and races. There was a significant seasonal variation in ruptured aortic aneurysm mortality, with higher deaths in the winter months. The incidence of ruptured aortic aneurysms was highest in Midwest states, followed by Northeast and West states, with the lowest in Southern states. Only 57% of ruptured aortic aneurysm deaths occurred in men over 65. These data show that the incidence of fatal aortic aneurysm drastically decreased in the United States between 1999 and 2016, and that a significant percentage of fatal ruptured aneurysms occurred in patients who are not currently eligible for screening programs. We hope that you enjoy this month's JVS and the other articles in this issue, and thank you for your attention.